Okay. Well, thanks very much, Edward, for your time. I really appreciate it. And I know that, yeah, there was a bit of a trouble with that I had with the time zones. I'm sorry about that. I really appreciate your time. So we've got about an hour from now, I guess, or you'll tell us when to stop. So I've got some questions here, but before I get into that, I thought it'd be helpful for the audience if they don't know you already, if you could give a short self-introduction about your background and where you've come from and what you do now.
All right. Um, well, my name is Eduard Verhagen. I'm a pediatrician and I work in Groningen, which is in the northern part of Holland, where I am the chief of the pediatrics department and the director of the Children's Hospital. I'm a professor in pediatric palliative care. Before I became all that, I studied medicine and law, both in Utrecht, in the center of the country. I trained as a pediatrician in Amsterdam. And then my first years as a pediatrician were in the Caribbean area, in Curacao, where I worked for about 5 years. It's at that place that I became to appreciate the differences in approaches towards death and dying, but also towards being born and live and life, all those things. I traveled a lot in the area there in South American countries and also elsewhere in the world where the interest, my interest in cultural differences became even bigger. When I came to Groningen, one of the first things that we had to deal with was a child, a baby with a bad skin disease. And from that moment on, I tried to build a certain structure that would prevent the dilemmas that we met at that stage with that baby for others in the future. So that's when I became really interested in and knew more about end-of-life decision making in general and pediatric euthanasia specifically.
As thanks. And so you became familiar with it in the Caribbean, and then I guess at some point you came back to Europe or to Holland. Is that right?
Yeah, that's
So,
exactly what happened. So
yeah.
there is Curacao is one of the islands that is part of the kingdom, so it was not a big step.
Okay.
And there is a educational and research tie between the hospital there and the hospital that I'm right now. So
I
that's
see.
why I chose Groningen, and that's how
Okay.
it went. Yeah.
I see. Okay. And actually, I mean, just as a curiosity, what was was the language there still like English or Dutch, or was it?
No, well, the official language is Dutch,
Uh-huh.
but most people speak Papiamentu, which is a funny and interesting mix of West African language plus Portuguese plus Spanish.
Wow.
And in most Caribbean islands and also in Curacao, there's a lot of traveling of people in between those islands. So there is on the streets, you would hear mostly Spanish, a bit of Papiamento and Dutch, but it's a colorful mix of
Right.
languages that's
Right.
going. Yeah,
And I guess a colorful mix of cultures and ideas about
absolutely,
life and death, as you said.
absolutely, absolutely. So very interesting from that point, that perspective. Yeah,
So
yeah.
I guess that it sounds like that was quite a formative experience for you
It
in
was,
your
yes, it
thinking.
was. Yeah. Also, it was an experience that was based on top of my basic interest in law and structure of the society and how do we try to organize behavior of people in general and medical people specifically. So I always found it super interesting that harming people is not allowed for most people, but if the doctor takes a knife and cuts you, it's okay under certain circumstances,
Right.
because
Yeah.
we have rules that make it okay and we think it's good. So those phenomena have always interested me. And in pediatrics, you find many of those interesting areas where ethics and law and medicine meet. So that is, it was already something very interesting to me. But in Curacao, I noticed that if you put difference in culture in this equation, it becomes even more interesting.
Yeah, no doubt. And you mentioned ethics in there. Do you subscribe to any particular ethical theories or moral philosophies of any particular description?
Mm, I don't think I can say that. So I kind of grew into ethics. I wrote my PhD on ethical subject and met a lot of people in bioethics world, medical bioethics world, and became more acquainted, more comfortable with certain theories. I told you just before we started this that I met Peter Springer, and 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 so that also influenced me in certain ways. I noticed that many people have given uh, life and death issues thoughts and energy, and so I was just curious to take that all in and and reflect on it. And I don't think I can say I have a particular um, stream I do. I like to develop. Still, my thoughts on the issue of life and death and dying still develops, and I use what I read and what I hear and what I experience to enrich my thoughts about it.
Yeah. So it sounds like kind of a pluralist approach.
I guess so. Yeah.
Yeah. Or would you prefer a different word or
No, it's good.
okay.
It's good.
Okay.
Yeah, I
Yeah.
like it. Yeah.
Okay. Well, yeah, that was really interesting, and I didn't know all those things about your background. Um, you mentioned that you're a professor now of pediatric palliative care. I think at the beginning. So for someone that is new to this whole discussion, what is pediatric palliative care? And maybe if it's possible, could you give an example of a common case and how that would present and how you would treat it?
Yeah. Well, to do that, I'm not going to give you the definition of pediatric palliative care because it takes about 3 minutes or 4 minutes to
Okay.
start. The WHO has a definition. I think
Okay.
it's interesting to know the definition, but even more interesting to try to describe what it is to me. Um, so to answer that, I'm working in a pediatric hospital where only the toughest cases come, and the usual pediatric illnesses go to other hospitals. And so it's a kind of referral center. And in pediatrics, if you look at who dies in the pediatric population, the majority is newborn, so between 0 and 12 months, and the rest until the 18 years of age. Uh, it's rare diseases, a little bit of cancer, neurologic diseases, and so early in life we know in pediatrics that certain diseases cannot be cured and they will end in early death. And palliative care is the part of medicine that tries to do whatever is needed to keep the quality of life of the child and the family as good as possible. And to be able to do that, we try to start discussions with parents and children, if possible, but that's not always possible, about what their views are on death and dying and on life with this disease and what they fear, what they want out of it, and we try to help them as good as we can. And so it's only partly medical. It's also involving spirituality in it. Psychosocial elements are in it, and it's multidisciplinary because of all that. And the decision making is only a part of it. And I think, to me, the interesting part of palliative care is that it forces people, but specifically healthcare providers, doctors, to think about their role and the role of their protocols and their approaches, how it can maybe differ from the usual approach when it concerns children that have very limited lifespan. So in adults, palliative care is often like weeks or months, and it's largely terminal care. In pediatrics, it's like weeks, months, or years that you provide palliative care. And the interesting thing to me is that doctors seem to be capable of aiming their therapies at the norms and values of parents when it concerns palliative care, but not when it concerns curative care. And ultimately, I think we should be able to aim our efforts at those norms and values all the time. So not only in palliative care, but I see palliative care as the area where it seems to be easier for most of us, that we should exercise that approach there and train ourselves in doing it. And ultimately, my wish would be that we were able to do the same thing and have that same approach where it concerns normally ill people like you and me when we get ill. I would hope my doctor would take that approach. And not only if palliative care is needed, but also when curative care is needed. So it's a kind of a philosophy to me, palliative care, which very much relates to how do we approach people that are ill, and what is our role in that. And that's what I try to discuss with residents here and students and also colleagues, and this is what is part of my job, I guess. Yeah.
Yeah, that's a really nice introduction, and thank you for that. For someone who's not a doctor, you know, it's hard for me to imagine what it must be like as a treating physician in the case of, let's say, a severely disabled newborn or a rare disease in a teenager or something like that. What is it like for you and for some of your colleagues? What are some of the emotions or feelings that you typically will have or have had in the past?
Well, I think it's an excellent question, Tom, because that's where differences start, cultural differences start. So the Dutch have always been more or less obsessed with death and dying, suffering and disabilities, in the sense that we try to prevent suffering and treat suffering wherever possible. And if there is suffering, we doctors feel guilty that they're suffering. So we take the suffering on our shoulders, and we also take adverse effects of treatment on our shoulders. And that's what we've taught ourselves, or we've been taught. So for example, the treatment of extremely premature newborns has been problematic for Dutch neonatologists in the sense that sometimes the child comes out without any harm or without any disabilities, but most of the time there is damage, and damage to the brain, damage to the organs, the lung, the kidney, and doctors feel bad about it because they feel that they should have done better to prevent that. So they're hesitant in starting treatment at an early age, and they're hesitant in continuing treatment if the quality of life in the future potentially could turn out badly. And so that is something that we feel strongly and that we bring to other generations. It's changing a bit, but that's basically how we feel about it. And so for us, the same thing happens the same thing counts for in adult medicine. So if there is suffering and the patient feels that this suffering is useless, or then it is a small step to ask the doctor to end the life. And so we have the autonomy principle very highly in our society, but also kind of a beneficence. So if the patient doesn't want to live, who are we to force the patient to keep on living? That is an idea that is strongly in the society, and it's related to our idea about suffering. And so there are other cultures and other countries, even also in Northern Europe, that have a different approach. They say every child has rights. As soon as a child is born, the right to the best health care is the first thing that we have in mind. So whatever the consequences, treatment will be given. And if it turns out great, we're happy. If it turns out less great, we're still happy. So that approach is also carried over from one generation to another. And so some of the Nordic countries, when they hear about our hesitance to start early treatment in very young premature babies, they cannot really connect to that because, whoa, what about the rise of the child? And look at the results. So even like 50% turns out super healthy. So we like to look at the 50% that don't turn out healthy, that have damage, that have disabilities, and others look at the 50% that are healthy and are also enthusiastic about the other 50% because less babies died. And we don't mind if the baby die. I mean, this is roughly speaking.
Of course, yeah.
We prefer death sometimes above a life with many disabilities. Now, this was the basic picture at least like 5 to 10 years ago. And I noticed there is some change going on, and I think it's an excellent change that's going on. But so basically that idea of guilt is still connected to pediatrics and disease, to us.
Yeah.
But you can understand it very much depends on your approach to illness, disability, humanity as a whole.
Yeah.
It's like the glass is half full or half empty. All those things, they differ in people and societies.
Yeah. And then of course also the norms and values of the parents and others around will be influencing.
We did an interesting study, Tom, if you don't mind, if I just
please,
talk about that a little bit, where we compared death and dying in the NICU in Groningen, and we compared it to similar populations in two large NICUs in the US and a large NICU in Canada. What we expected
Sorry,
was that
NICU is
a
neonatal intensive
neonatal
care.
intensive care unit. Yeah, so we found a way um, to compare the babies that were treated there and were admitted and died, and the ones that live, in categories, and those categories we compared the decision making in. And we expected that to be the outsiders, the outliers, because we value so much the future quality of life, and there was at that time so much criticism against how we approach our parents and patients. But it turned out that the opposite was true. So in terms of allowing quality of life as a criterion in decision making, there was one center in the US and the center in Canada that did comparable things as we did. So around 50% of deaths in the neonatal intensive care units were not babies that were busy dying, but they were babies that could live on, but it was decided to stop the treatment and let the child die because of the expected quality of life. There was one center in the US that never stopped treatment based on quality of life, that always continued treatment until either discharge or death. So that was an example of how not only countries, but even hospitals can differ in their approach towards non-treatment and continued treatment towards death and life with or without disabilities. And I think it's interesting to see that. I cannot fully explain it. I can partly maybe explain it. We asked, of course, those doctors, so why are you doing this? Because like 150 miles more north, there is a center that does the opposite of you. How does that work? Does it make, obviously it makes a difference where you're born, either in this case, Milwaukee or in Chicago. How is that explainable? And so those differences and maybe even inconsistencies, I find them very, very intriguing. And I try to explain them. I try to contribute by making it visible and hoping that people discuss this.
Yeah, that's very interesting. And of course, yeah, not only within those hospitals, the treating doctors and maybe the hierarchy within that hospital might have different views, and
Yeah, yeah,
patients, of course, and yeah,
yeah,
I guess there's a lot of differences, a lot of maybe polarity and complexity which you experienced way back when in the Caribbean. Um,
absolutely.
yeah. Um, as a sort of technical question, you mentioned, sort of future quality of life and suffering and things in newborns. How do you actually assess that clinically? How do you know when a newborn is suffering, just in a sort of basic approach?
The 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 older the child gets, the easier that becomes because you can involve the child. Suffering generally is seen as subjective phenomena, so you need the patient to be able to assess suffering. But if the patient cannot communicate, that doesn't mean that there's no suffering. So we need other tools and we need other ways to determine whether or not there is suffering and whether or not there is suffering that is unacceptable. So in neonatology, there are several ways that we can at least make a basic assessment of the suffering. And I think there are intuitive tools, like if a patient has pain, the heart frequency will go up, there will be crying, there will be facial changes, and the fists can give it away. There are some elements that we could find in the blood, although we hardly use it. And for the rest, we are depending on our knowledge of what goes on in the child, the diagnosis, the diagnostic um, um, things that we've looked at, the MRIs, the EEGs, so the cerebral function, and our knowledge of how this develops over time and what it results in. And all those things we use. Also, very importantly, we use the parents and the nurses' evaluation of the child. And obviously, there are babies where everyone would say, this child is not suffering because here is a happy pink baby and doing everything that all babies do. So there is no suffering here. We cannot measure it, but this is what we think based on experience and on observation. And there at the other end of the spectrum, there is a child that is always restless, continuously cramping and making moves and maybe also having seizures and things. And if we know the cause of the seizures and we know that it will not get better, it will get worse, those are the babies that we would say the prospects of a life, a livable life, are so poor, and the suffering is not immediately measurable, but it must be present. And so we must intervene. And then the intervention usually is sedation, pain killing, but then the question comes, so what kind of future is a future where you're constantly sedated or you're constantly suppressing pain and emotions, and this is where often parents come in and they say, we think this is not a life that we want for our child. And that is a very important part of the decision making. So some parents would say the opposite. They say everything that we get is welcome and we'll make it work. But let me put it this way. In the Netherlands, most parents would say this is useless suffering. And let's talk about making this life as valuable as we can from our point of view. And that may include not extending it. That may include even stopping it. And so that would mean ending the life. So those discussions are coming when suffering is clear and untreatable or very difficult to treat, or the consequences of the treatment are unacceptable. And that doesn't happen a lot. I mean, most of the we are so good in medicine nowadays that we can prevent suffering, we can treat suffering. But even now, there are some cases that are so tough, and those are the heartbreaking cases for everyone around the world. I mean, how do we deal with it? And if you put on top of that the feeling of guilt for the doctor, they say, "Oh, it's my fault. I should have prevented it." That makes it hard. So if you don't have that guilt feeling, it's also hard. But if you have that idea that it's on your shoulders, it's even harder.
I don't envy your position at all. That must be very difficult.
Yeah.
You talked earlier about protocols, and you've just described a lot about sort of the process of understanding the mental sort of state and the potential suffering of newborns. In 2004, you led the development of the Groningen Protocol. I'm sorry for my mispronunciation.
Yeah.
And that outlines medical and legal protocols for euthanasia in infants without legal consequences at that time. Already described a little bit about this, but maybe could you just speak to its development and its reception, and what's the status of that protocol now?
Yeah. So we I think the first step of understanding that protocol well is to know that in the Netherlands we do surveys about death and dying every 5 years. So we've been doing that since 1990, I think. So every 5 years, doctors are anonymously questioned, a lot of doctors, about cases that they had of adults and newborns that died. So everything about that decision making and the actually end of that life is questioned. So there are questions about that. So we know quite well how our population dies from which diseases, but also how the decision making goes, and also how the actually dying takes place, which medicines are used or not used, what the position is of feedings and hydrations. And so the doctors are used to share that information anonymously, and it's plotted every 5 years. We know, and we use it as a tool to find out how is our end of life care and decision making, and how is it changing. So, for instance, when there was a euthanasia law for adults in 2002, we were all very interested in the next survey to find out, did it really change end of life care and end of life decision making, and how did it change? And so we've been doing that for many years, and those surveys have showed that from the first surveys in 1990 to well in 2000, there have always been cases where doctors ended lives of newborns, and they anonymously explained all the details. And they were not like huge numbers, but still it was happening, deliberate life ending in newborns. And nobody really knew who those babies were, who the doctors were. And many of us didn't really understand how did that work. And so that was the area before the protocol. When we had this particular case of, it was a skin disease called EB, epidermolysis bullosa, and the type that this child had was lethal. So we knew the child would die early, like the first few months of life. And the parents asked us to end the life because they wanted to prevent those months of suffering. And they were right. Those months would have been horrific. And for them, that was unacceptable. And we could agree on that. We, like, from a medical point of view, it was a logical thing to ask. But at that time, it was illegal. It was like considered murder. So even doctors are not allowed to just end the lives of people who don't ask for it. So we, at that time, talked to healthcare lawyers, to the prosecution locally and nationally. And we tried to find a way to honor the requests of the parents, but we couldn't find it without the risk of being prosecuted for murder. So we did not end the life of that baby. We sent her back to the referral hospital, and she died like 2 months later. And those 2 months were not good. So when we heard about her death, it was a baby called Bente. We were rethinking our strategy and said, well, this was not good medicine. We should try to do it differently next time. And we really went more into depth about, have there been any cases or court cases in this area? How can we find a way to do what we felt was best, but were afraid to do? And at that stage, we found indeed 2 court cases that had played in the 1990, 1993, and 1994. And we used those verdicts because they were helping and helpful. And ultimately, we took all those elements, like the legal elements, but also what nurses and doctors and parents told us, and we made this protocol, which is very similar to the adult euthanasia law. And the biggest difference actually is that, of course, the patient can never ask for euthanasia, which is a requirement in the euthanasia law for adults. So we put the parents at the same level as the patient. So we said if the parents ask for newborn euthanasia, that should be enough. And then the same system should work, like the medical team should make their own evaluation, and if they can agree, then the request can be honored. If they do not agree, they will not do it. And also if there is no request, it will not be done. So that idea was put into a protocol. To be honest, it was at first a protocol only for our own hospital. We see a lot of EB because we are kind of referral center for the country. So we said, if there is another case coming, maybe in a few years, then we take the protocol and we should be able to do it. There was also agreement and cooperation from the prosecuting office in finalizing the protocol. So we felt comfortable. And we felt comfortable enough to discuss the protocol in a television program in our country, which was seen by journalists writing for Italian and Spanish papers. And that's where the uproar started, because they wrote that we killed babies on large scale. And they said things like, look what they're doing. The Dutch have allowed soft drugs, abortion, euthanasia in elderly, and now they even start killing babies. And the numbers that they mentioned, like the hundreds every year, I don't know where they got it from, but this is how it was put forward. So we got a lot of criticism from everywhere around the world. People were shocked. Not all, but many people were shocked. And on top of that, that really didn't help. The Vatican became involved. They wrote a nasty piece in their Osservatore Romano, which is a journal of the Vatican, about me and about Groningen and about our protocol, which was similar to what the Germans did and the Nazis. So it was very unpleasant. But because it was the Vatican, it got a lot of attention and it increased the temperature. And we didn't know really what to do, because this is unusual for hospitals. You try to make good name in research, and then this happens. So we were not happy. But the only thing that we could think of was explaining and explaining and explaining. And we were helped a little bit in a very, very peculiar way. When we talked to the prosecuting office in The Hague, in part of Holland, about newborn euthanasia, they said, well, we have cases where those cases that were in the survey, we can give them to you, and you should analyze them, and you should publish about it for Dutch doctors, so you know what cases were euthanized even before it was allowed. And those cases we did not prosecute, because we felt they were within the scope of those court cases that were there in the 1990s. So we got those cases and we analyzed them, and they were super interesting, because unexpectedly they were all spina bifida cases, and they were all cases where indeed life was deliberately ended carefully after many discussions and second opinions, etc. And they were indeed not prosecuted. So we published this for Dutch doctors in Dutch in a medical journal that is only distributed in Holland. But somehow this was picked up by an editor of the New England Journal of Medicine, which is one of the big medical journals. He called me at a certain day and said, well, this is my name, this is my role. I know you wrote something about the protocol and about the case and about about analysis of cases, but I'm unable to read it. So could you tell me what it is? And so I told him the story and the outcome of the analysis. And he said, you should write it. You should write down everything and I'll publish it. And this is what happened. And that was a kind of a mark in the developments, because when it was published, people started to react differently, especially if the medical profession said, well, we know those cases and they give us headache and belly ache and moral distress. So we're happy to see that you found a way to deal with it that is open for review and transparent, and we should try to take part of it to our community and see how we can do better. And also parents and people from sports and arts, they reacted to it. The New York Times started writing about it, which also did a lot of good. So we started with like 1,000 of hate mails a day, and then they became fan mails in a certain way, and the environment and the temperature changed. And from that moment onwards, it was like more an element of discussion, at least in the medical and bioethical world. Of course, also in those two worlds, there are people who are in favor, and those who are against it are always also present. But at least we're discussing it, and it is not as hot now as it was then. And there have been some interesting developments. So it has become more accepted. We're still the only country in the world that has a regulation for it, but I think at least people understand the context of the regulation, and that it's not surprising that we are the country that has it. So interestingly, one of the elements that was feared most from our regulation, from our protocol, was what people call the slippery slope. Once you start doing this in the toughest cases, you'll see that soon you'll be ending the lives of so many babies for less good reasons. And so we were happy with the survey system, because we could clearly demonstrate that after legalization of newborn euthanasia, the cases did not go up, they went down. And so that helps. It helped. The obsession of the Dutch in this particular area helps us to be able to monitor how newborns die and know exactly what is changing, and then focus on the change and try to find out why is it changing. So that is something that I would recommend to other countries. Try to monitor what is happening. Try to find out how people actually really die, because we read hardly about that. People don't publish easily on how it actually goes. They like to publish numbers and diagnoses, but how it really went. And I think that is the interesting thing. How does it really go? How far are we prepared, and are we allowed to help people in dying in a way that is good for them and not? So that's where law and ethics and medicine, they mingle in a funny way.
Yeah, and I guess you want those discussions to be not just focused on, these really horrible, unfortunate circumstances, but to really spread throughout all of medicine into the curative and even maybe preventative medicine practice. Yeah.
Absolutely. Yeah.
And I'm very sorry to hear, by the way, of those circumstances early on. It sounds like that must have been most traumatic to face.
It was tough for many people working here, but it would probably be even more tougher nowadays. At that time, social media weren't so big as they are now, and I think I was very much, I was very happy with the support that the hospital gave, because they could have kicked me out. It would have been easier, it would have solved a problem. But so that was a good thing. And also my colleagues were very supportive. And interestingly, so a lot of criticism came, but within the country, there was not much discussion, because for us, it was such a logical step. If you allow quality of dying for adults, then it's a small step to allow quality of dying for the adults that take care of a severely damaged child. And so the main thing for the Dutch is transparency. Make sure it's not abused, make sure it's reviewed, make sure that everyone is held accountable for every step that they're taking. And so it didn't do much in the country, and it still doesn't do much in the country.
See. Um, we have about 10 or 15 minutes left of our scheduled time. I wanted to ask you about conceptions of personhood. So sometimes in ethics and law, people talk about legal and moral personhood. For example, a newborn infant might have some level of personhood, but not in the sense that they cannot really intend on doing anything, therefore they cannot maybe be prosecuted for murder. Whereas if someone kills the baby, say maybe a perfectly healthy baby, then we would potentially consider that murder. What do you make this distinction, or how do you think about personhood?
Well, um, there's a lot to say about that, but I think to me, generally spoken, from the day a child is born, there is, to me, a person and personhood, and probably before that, somewhere, that personhood starts deserving protection. I tend to see the life-ending activities of other human beings a bit separate from personhood, or maybe not separate, but so my approach would be, suffering is something that we should try to prevent, because it ruins lives. And I don't believe suffering has a purpose. So even before birth, if there's clear suffering, I think there is a task for us to limit it or end it. And then, to me, the most important element is who decides about that. And is it society that decides how we approach this individual? Or is it the individual itself? Yes, but not when the individual is too young, because there is no way to do that. So to me, the role of the parents is very, very clear. They are the ones that are responsible for guiding the child in every way in the first years of life, and help the child develop to a human being that is capable of taking his or her own decisions. And so to me, if this suffering is too much in the perspective of the parents, too much to bear, then I would easily go along with that, because I have no higher standards or better idea of I do not know better than them. So probably the only boundary that I keep in mind is if it is clearly ridiculous, I mean, clearly ridiculous, that I'm not going to support. But that doesn't happen. I mean, I've seen so many parents of children with so many diseases. I am very trustful towards parents. They guard the child, they guard that person that they love from even before birth, and they should be allowed to have a huge say in what others do to the child or don't do to the child. So I feel that there is a person in the crib, and I see that parents are the best people to guard that person, and irrespective of the disease. And the best boundary to keep in mind to me is ridiculous, absurd behavior. But I don't know. I haven't come across absurd behavior in that
Right.
area.
There's not much time, but I did want to ask. I feel like I have to ask because I'll probably talk about this in the main video. There was an article published in 2013 titled "Afterbirth Abortion: Why Should the Baby Live" by Francesca Minerva and Alberto Gubalini.
Yeah,
Have you read this, or are you
yeah,
familiar with this? Yeah.
yeah.
What's your opinion on that article?
Well, honestly, I like it a lot. I know it's controversial, but I like controversy because it does something to people's thinking, and it may change approaches uh, where other things fail. So I embrace it in a certain way, and the fact that people feel free, like those authors, to write about this in the way that they did is something that we should cherish. Many people don't agree, but that is not a criterion. So to me, that is not a criterion. I think the idea of comparing pre-birth criteria for decision making to after-birth criteria is excellent, because we are inconsistent in many ways in that area. And so if you write a non-controversial paper about it, it won't help us. You have to name and describe as good as you can what the inconsistencies are and how they could be managed. And so I see it as a valuable paper, but at the same time, I am certain, and I know that the authors got a lot of criticism, and it even probably interfered with their careers. And I don't understand that. That should not be the case. Let's please be outspoken and controversial at times, because it forces us to rethink our strategies and protocols and so, well, yeah, that's basically my idea about it. So they should be applauded and not hanged, but the opposite happened, I think.
Fortunately, I think so. Yeah. Do you, so yeah, it sounds like you definitely support their expression and their analysis method. Um, I I might misremember, but one of their conclusions seemed to be that, basically, uh, infant euthanasia, even of a healthy child, is potentially okay for economic reasons, if that person might have otherwise had an abortion for economic reasons. Do you have anything to say about that, or if you wish, you don't have to? But
Yeah, but I think you're right in mentioning this. I see the paper as an exercise and a way of making visible where inconsistencies are. Implementing that idea, implementing that exercise is a different thing. So to me, the important thing is to discuss with people, why are we allowing those pre-birth criteria like economic status, like social elements, and forget about them after birth? How can we connect those two in a better way? I'm not a person that says we should allow euthanasia for the same reasons as we allow termination of pregnancy. But I think we should address the inconsistency and make sure that we use them to improve our decision making and our structure. So it's extreme what they're saying, and I use the extreme to point at inconsistencies that are also present in our system, and I use them for discussion. I'm not a fan of implementing it, and I don't think it would work in our society. But I'm not sure that was the intent of the authors. I think the intent of the authors was to show us, look what's happening. This is weird, and if we stick to the idea that we have pre-birth, then that would be the logical thing to do after birth. I don't think they're saying we should tomorrow do that, but I think we should rethink our policies there.
Mm.
But that's the way I like to read it.
Yeah. Well, yeah. Thank you for sharing that. And I just felt I had to ask because I will mention it in the main video.
Yeah.
So I think we're almost approaching the end of our time. I really appreciate your time, and we've discussed some heavy topics. So just as a final kind of question, I wanted to ask, like, what are some of your hobbies, and what are some interesting fun facts about you that you would like to share?
Well, so I think you're going to share this also with students.
Yeah.
And one of the things that I really like is teaching and talking to students. And I usually try to inspire them to follow the news, because we're getting to a new point in the Dutch healthcare system where we're going to allow euthanasia in older children between 1 and 12 soon, and use that as an example or as a way to provoke them to think about that. And I noticed that it's easier for people to think about older children than for newborns are in the area of less personhood, less valuable. We don't love them yet, but children we love when they're older. So that I use a lot, and so one of my hobbies is teaching. For the rest, well, you must have noticed the shirt here on the back.
Oh, yeah, please tell us about that.
Yeah, I like to bike. So we're doing fundraising tours every now and then, and the funds we raise for the pediatric hospital for sometimes needs of parents or make new research plans, and then afterwards I try to sell the shirt and the accessories and give it to the fund again. So I spent a lot of time in sports and biking, and I noticed that it's an excellent way for me to, I'm not sure if it works that way, but I like to think that it works that way, to have blood flow in areas of my brain that are usually not filled with blood, and I get great new ideas when I do that. So I would like to take this minute to recommend to everyone who's listening or looking at your video to do the same.
Yeah.
make sure you stay healthy, and exercise and biking is an excellent way to do it. And you might also have those areas in your brains that when the blood starts flowing, there are great ideas that you want to work on, and well, things like
Yeah.
that.
Yeah.
So that is
Great.
part of the time. And for the rest, I'm also a father of 5 kids, so
Wow.
they
Okay.
take a lot of time, and which is great. And that's it.
Great.
Yeah.
All right. Well, look, thank you very much, Edward, for sharing your time. And I'm sure that, yeah, people will find some of your information useful. And I might ask that you send some uh, links or things if you want later, and I'll put those underneath in the video.
All right. I enjoyed it, Thomas. Thanks.
Yeah. All right. So we'll stop the recording now.
Excellent.